Reading your report, um, you concluded that Asian Americans have the highest percentage of mortality rates from COVID-19 in San Francisco. Were you shocked when you saw that data, or what was your first response?
Yeah, I had a sort of a dual response to it. The first was, yes, it was shocking to find out, over half of the deaths in San Francisco from COVID were Asian American. As a researcher, though, my first response was also, these numbers are kind of small. So we kind of always interpret small numbers with a lot of caution. We don't want to jump to any conclusion. The data coming out of the state of California, though, is sort of reinforcing that. So, and of course, the data out of California is obviously have a lot more numbers. And so it makes us realize, it wasn't until I saw the data from California that I thought this was something that we need to sort of make the community be aware of. So,
could you state the data coming out of California, and does it show roughly the same percentage?
So the percentage among San Franciscans is 6.7% of Asian Americans who have infected have died. Right. And the data coming out of California is 8.2%.
Wow.
The difference is between the San Francisco and the California data is that in San Francisco, the overall proportion of deaths to the number of cases was only 1.8%, but it was 5.6% for all Californians. So Asian Americans remain the group with the highest proportion of deaths to cases in both places. But the difference between the Asian American data and the general population data is smaller across California than it is in San Francisco.
Wow. And I know we've talked about this before, but what contributes to some of these high mortality rates? What are they environmental factors, genetic factors?
So first of all, the data that we have doesn't give us the answer. So, but there are sort of some potential explanation that we can explore to try to understand more, right? So what we're giving is a proportion, which is the numerator is a fraction. As a numerator is the number of deaths, and the denominator is the number of people diagnosed with COVID by testing, right? So a proportion can be high if the numerator is high or the denominator is low. So let's look at the denominator first. The number of Asian Americans infected with COVID-19 and confirmed by testing could be artificially low because, number one, they don't get the testing, right? Relatively compared to other population. Again, I'm not saying that that's the case, but that's one potential explanation. It does point out, it wouldn't be surprising if that's the situation, because a lot of Asian Americans are, if they're older, the immigrants, they don't speak English, and the testing is really based on access to care, then that could be a problem. We need to look into that by looking at actual rates of testing among these populations. So that's number one. Number two could be that they are indeed having more deaths given the number of cases. And then the question becomes, why is that? And the explanation for that can be kind of complicated. One explanation could be that they don't have adequate access to healthcare, so that when they get sick, they get seen later and get sicker. That's a very common explanation. Another explanation could be that the people who are getting infected just happen to have a lot more health issues. One of the things that we haven't seen data for is the age distribution of these populations who are getting infected and dying. Right. So, if for some, some reason the Asian Americans who are getting this happen to be older, they are more likely to die from it. So that could be another explanation. And the last explanation that could be, possibly true is that healthcare workers get infected a lot. And of course, when they get infected, they are often exposed to bigger doses of the virus than a person in the community. A person in the community might say, they get into contact with someone walking by, they inhale something, and they get a certain amount of virus. A healthcare worker is usually working with someone who's both very sick. About 1 out of 6 doctors and 1 out of 11 nurses are Asian Americans, which is a lot higher than our proportion in the population. Asian Americans also can comprise a big part of the caregiving population, whether it's in-home support or other types of sort of caregiving besides nurses and doctors.
Yeah, one of the things that we had discussed at a previous panel was Asian Americans tending to live in more concentrated households, multi-generations of Asian Americans all living together in the same house. Does that explain the higher percentage of Asian Americans dying of COVID-19?
I would say that is probably more likely an explanation for more Asian Americans getting infected. I don't, the sort of underlying issue there might be that they're living in multi-generational household or more concentrated housing because there are lower socioeconomic status among those communities. And that obviously has a determination in terms of, health outcomes. But the concentrated living raises the risk of transmission rather than inherently having anything to do with mortality.
Interesting. And you had spoken about in your summary, you had spoken about the need for disaggregated data by Asian American community. You did not have access to that data in this report, is that right?
Yeah, right now, as far as I know, there is no Asian American data on COVID-19 that's actually disaggregated by what we call national origin groups. So whether or not you or your parents or your ancestors came from China or India or Vietnam or wherever it is. So there is no such data right now for us to look at. I think with pretty much any kind of health data or any kind of data really on Asian American, looking at the overall population often will obscure very significant disparities. And I'm not talking about COVID-19, I'm talking about other types of diseases. For example, if you look at diabetes rates, in aggregate, you kind of miss the fact that Filipinos in particular have really high rates of diabetes compared to other Asian groups. Or if you look at the rates of, say, liver cancer, you're going to miss the fact that Southeast Asians have more liver cancer than other Asian groups. So we know that to be a fact of many health conditions. We need to see disaggregated data. So whether or not we'll see this in COVID, I can't predict, but I will say that we do need the information. The other reason why disaggregated data is really important is that if we want to reach out to certain population, if they're at higher risk, without the disaggregated data, we can't do that. And with Asian, it's really important because a lot of the outreach and intervention work that we do has to be culturally and linguistically appropriate, right? So if you knew that, for example, more Chinese were somehow affected, you can create an intervention where you can do more Chinese language outreach and things like that. Without that disaggregation, we can't know that there's a problem, and we can't design interventions that will help resolve those problems.
Absolutely. We know that for Latinos and the African American community, that underlying conditions such as the ones you just mentioned, heart disease, hypertension, diabetes, tend to be contributing factors to mortality. Are there specific conditions within the broad Asian American population without disaggregated data that also contribute to their high risk of mortality?
Yeah, so I can't say necessarily that Asian Americans have higher rates of, say, commonly thought about things like asthma or diabetes compared to other racial and ethnic group. That is really, I think in disaggregation, some Asian American groups have high rates of some of those conditions. One of the sort of emerging things that I heard about is in COVID patients, the risk of having strokes and what we call thromboembolic disease, clotting types of diseases where the blood clots excessively, seems to be more of an issue. And Asian Americans in particular do have somewhat higher risk of having strokes of certain kinds. And so, again, some of this is really just hypotheses and speculations, but it's possible. I mean, that Asian Americans do have some conditions that is put them at higher risk from dying from COVID-19.
Okay, But at this point, you cannot say what those conditions are.
No, I think what we are going to try to do, if we can, is to start looking and or asking the health departments to report more on these, what we call the comorbid conditions of the people who are dying. Some of the factors that we really want to know, number one, is what are the ages of these people who are getting infected and dying, and who are dying from COVID? What other medical conditions do they have? And until we have that data, it's going to be hard for us to state with any kind of certainty. We're just right now, this is research brief that we put out, is what we call hypothesis generating and awareness raising. Awareness raising in the sense that, hey, there might be a problem here. We need to invest more in finding out why, whether or not this is true, and why this is happening. And hypothesis generating for researchers, because then we can start looking for potential causes, as you are asking right now. You know, my father feels, he's 85 and he's Vietnamese, he's Asian, and he feels like he's not highly vulnerable. And of course he is, of course, in one of the most high risk groups. But I also don't want any Asian Americans to be walking around thinking that they're less vulnerable than other groups. They need to understand that they're certainly at the same risk, and they may be at higher risk of dying from COVID-19. And the second thing we want people to be aware of is policymakers to see these numbers, and for the press too, obviously, to see these numbers so that they can make the case that we need more data. With Asian American work, we are often the least study of many groups because we're thought to be, you know, this mono-minority myth of we're healthier and we're doing better than other minority groups. And so if there is limitation on resources for data collection and research, we're often at the bottom. And so if we don't sort of raise the awareness about this, we may not actually get the data that we need. So that's one reason why we kind of released this a little bit more earlier than we have the answers to.
Absolutely. Does San Francisco have the resources to test everyone that needs to be tested? And are you seeing that kind of outreach happening in the Asian American community to actively promote testing?
You know, my sense of it is that there is adequate resources in the healthcare systems, like, you know, at UCSF, the county hospital, and so on and so forth, to test people who have symptoms. I don't know if we have enough testing for testing what we call asymptomatic people, which you know, it is important because, you know, I think a lot of people believe, and I do too, that the actual number of people infected with COVID is probably higher than the testing rates, right? Because there are people who don't have symptoms. There are people who have very mild symptoms and never seek health care. And so I don't think that we have that capacity yet. I can't speak for any particular healthcare system on that. What was the other question? I'm sorry, there was the second part.
Trend statewide?
I'm sorry?
Would you say that that's a trend statewide, that the state does not have the capacity to test asymptomatic people?
I think that's true. I don't know what the health departments are seeing, but I think that is, I don't think we have enough testing. I think we certainly are doing better on testing than we were 3-4 weeks ago. And that, I think, is part of the problem with when we think about making policy decisions around reopening. One of the big problem with the spread of COVID-19 is, you know, if one person is infected, how many other people can that person infect, right? And
right.
Without adequate testing numbers, particularly among those who gets infected but are asymptomatic, we can't figure that out. And that's actually a big decision, big factor in how fast the pandemic will come back if we reopen.
And again, you know, you were talking about the condensation of the community and you know, how that might contribute to the higher rates of infection.
Social distancing is a privilege. In other words, the idea that someone can stay away from someone at 6 feet or isolate at home when they have some symptoms, it's all dependent on the fact that you have a room that you can isolate to, right? So I mean, if you live in a family, and I've had patients who live in, you know, studio apartment with 2 or 3 family members, how do you isolate? That's just really not possible. And so we have to be aware of these situations, particularly among lower income, lower socioeconomic status Asian Americans, that once the infection takes hold in one person in that family, it would be really hard to keep it from spreading to the other members of the family, even if they're trying their very best, because just the physical and housing limitations. I'm not sure if that answered your question, but
yeah,
yeah.
It does. It does. Absolutely. Have you been able to compare this data to data, say, in New York, New York, New Jersey, which have the highest rates of infection currently, and some of the highest populations of Asian Americans as well?
Yeah. So we looked at, there's a website on the brief that actually people can go to. And I looked at that, and in that particular website, what they reported was the proportion of Asian Americans in the population and the proportion of Asian Americans as far as deaths are concerned. And 8 other states had similar findings, but I had to be very cautious about that because the numbers of Asian American deaths in those other states were a lot smaller. So it makes it even more difficult to know whether or not that's a true finding versus a random finding. Mm-hmm. And New Jersey and New York were not among those 2 other states. So in other words, again, very rough data. You need a lot more deep dive into it, but we are not able to confirm that in the bigger states with large number of Asian Americans. It doesn't mean that the phenomenon is not there, or we dove deeper that we couldn't find out some more stuff, but no.
So may I ask you one last question? Has there been correlating data to show that in the last 2 months, as people shelter in place, that there may be a lot more deaths at home? And do you think that the numbers are unreported, given that maybe a greater percentage of people are dying at home?
I would say that is true. I mean, if you look at the death rates coming out of some of the states, particularly New York, they're constantly being readjusted upward, and I think that's the case. I think people are, again, if you sort of follow that sort of cascade of I'm sick and I don't have access to health care, and I can't go to the hospital, or I can't afford to go, or I'm worried about, et cetera, poor and immigrant minority populations would be at risk for that, and that they would die at home. And if they're dying at home, they may not be tested for COVID. And so we would not necessarily attribute those deaths to COVID. So I think that the COVID deaths that we're seeing is definitely an underestimation. I think the question is there a disparity or a disproportionate way that those deaths are happening that actually underestimates the deaths among minorities? And I don't know the answer to that question, but I would think that would be likely given the way our healthcare system works.
When an Asian American does make it to the hospital, do they have access to the same quality of healthcare that other people might have, or is there a disparity in the quality of healthcare for?
Yeah, I think it's almost a given that unless you're going to a hospital that is really optimally set up to deal with a multicultural, different cultures and different languages, that Asian Americans, particularly those who don't speak English well, who are recent immigrants or first generation or older, will get at least less quality of care in terms of communication. And in other words, if they need an interpreter, they're lucky to get one. And if they get one, they may get one interpreter event during the whole day of hospitalization. And you can imagine that during a whole day of hospitalization, they may be talking to different nurses, different doctors, et cetera. And they're lucky if they have one of those big conversation be interpreted if they don't speak the same language. In San Francisco and in California, we're slightly more, we're somewhat better off just because of the healthcare workforce tend to be a little bit more diverse and speak more languages. But in general, I think the quality of communication is not as good. Satisfaction with care is not as good. It's not entirely clear that the quality of the actual healthcare being delivered in terms of testing and medications and all that stuff is not as good. But there is definitely different quality of care being delivered.
Absolutely. Are there any, is there any additional information that you'd like to add to the conversation?
Yeah, just in terms of the data, I actually, after we sent out the brief, a colleague of mine in UCLA showed the data from Los Angeles. Of course, data from Los Angeles is also captured in the California data, so it's nothing different than what we have. But the data from Los Angeles is also kind of compelling, and I'll just say it. So the proportion of deaths to cases among Asian in Los Angeles County is 13.7%, and that is the highest in LA County. African Americans, which is thought to be the group that the most highest risk for COVID disparities, has 13.5% proportion of deaths to cases. Latino was 5.9%. Native Hawaiian Pacific Islander was 6.7%, and white was 11.2%. So again, sort of the indication that Asians, a proportion of deaths to cases for Asian, the problem that we're seeing in San Francisco is similar in Los Angeles, which actually has a lot more deaths and cases than San Francisco does.
Thank you so much. It was a pleasure speaking to you, and we'll see you on the next call.
Well, yeah, thank you for having me on and to spread good information and evidence to our community. Thank you very much.